Hello, I'm Paul Farmer, an infectious disease physician and an anthropologist as well, and I've been working in delivering, along with many thousands of others, care in settings ranging from Haiti to Rwanda and here in Boston. And I'm going to talk today about ways to manage chronic infectious disease that I believe have some significance for medical care delivery going forward in general. And I'd like to start just by mentioning the agenda for this hour, and that is that the future of infectious disease practice will, of course, be impacted significantly by the emergence or persistence of diseases in settings far from the United States. And we have only to think of Ebola, but also the other illnesses that I'll speak about today, HIV disease and tuberculosis. They're pandemic diseases, and clinicians should be aware of them and how to manage them effectively. And I'll use as my example our experience providing care for these diseases for adults and children in both Haiti and Rwanda, and suggest in closing how these lessons might be applicable in contemplating other chronic disease problems, including those not caused by infectious pathogens. So let me just lay out the argument very briefly, and that is the era of modern medicine began in some senses with antibiotics. This is probably disputed by some, but most would imagine would agree with that proposition. And I'm showing here a slide put together by the house officers at the Peter Bent Brigham Hospital, where I teach many years later, a better part of a century, just to look at mortality rates for subacute bacterial enteritis in the pre-antibiotic and then with the introduction of penicillin. And this will surprise no one. And the point that I'd like to make here in contemplating these more recently identified infections such as AIDS or Ebola, or complications of long-known infections such as drug-resistant tuberculosis, the argument is the following, that when we have a new treatment or a new preventive, like a vaccine or new therapeutic, having some strategy for equitable delivery of that treatment is an important thing to do. And that's what the group I work with, Partners in Health, has done over the last 25 years. Another example for a reason for optimism is just to contemplate how much improvement there has been in the course of a number of very common afflictions, and just looking at heart attack death rate, for example, of the last few decades, or how I remember when I began my fellowship training, my residency in medicine or fellowship in infectious disease, there was a certain kind of fatalism about bloodstream infections. If you use catheters, you're going to have bloodstream infections. But the entire point of improving the delivery of care, and care can include prevention, is that we can do a lot better. And as has been shown, again, these are some Boston teaching hospitals. These are slides from a colleague of mine from the Brigham, Tom Lee, which shows just how much improvement can be expected when we take a systems approach to thinking about the clinical care we provide. So to return to one of the biggest and I think best examples in modern medicine is HIV. If you think about it, from the time of discovery of the new syndrome or description of the new syndrome to discovery of the virus, to very good tests to identify it and to stage the illness, only a few years elapsed. And now, less than 30 years, or just about 30 years after the discovery of HIV, we've seen massive improvement in our understanding of pathogenesis, but also in our ability to reduce death due to advanced HIV disease. And most astoundingly, these discoveries have been delivered to people who've been previously shut out of modern medicine. That includes people living in poverty across the continent, of Africa, but also in places like Haiti and indeed across the world. Pretty soon there'll be 10 million people receiving daily therapy for HIV disease, and that's a really stunning story. This slide every physician ought to know about. It just shows how rapidly age-adjusted rates of death dropped after the introduction in the mid-1990s of combination therapy, or ART, in the United States. Now, I happen to be an infectious disease fellow during that year, because it really did occur very rapidly, but had long been going between the Harvard teaching hospitals where I was training and Haiti, where I've been lucky enough to work with Partners in Health and its Haitian sister organization. And you can imagine the situation was very different there, and this is just an image of how profound also the impact of antiretroviral therapy has been on the size of the pediatric epidemic in the United States. Again, back in the 80s, it was assumed, since we knew that there was significant transmission from mother to child, that there would be a major epidemic of pediatric HIV in the United States. But this has not really come to pass, in large part because of a systems approach to implementing the preventive of choice, which again was antiretroviral therapy, and when used in combination, prevents almost all cases of so-called vertical transmission. So those were the two deliverables that we did have in the mid-1990s in the United States. We had suppressive therapy for HIV disease and a means of preventing at least the great majority of cases among children, but also probably preventing transmission in the event of needle stick or other exposure. Now, what about the rest of the world? Well, Haiti offers a good example, and some of these, I put some sources for some of these numbers here. It was a very substantial epidemic in Haiti. It was probably per capita the largest epidemic, with a prevalence estimated by some sources as between 5% or 6%. And among young women attending prenatal clinics in urban settings of urban poverty, it was substantially higher, usually 2 times higher. This was sometimes called a generalized epidemic, meaning it was difficult to discern who was at risk and who was not. But because women were so heavily infected, as you might expect, there was a very significant pediatric component. So AIDS became, in Haiti rapidly, the leading cause of death of young adults and also children, and it became the leading cause of death of young adults in the United States as well. But as I mentioned, the pediatric epidemic was forestalled to a significant extent. And AIDS, of course, led to a lot of orphanings in Haiti as well. In the rest of the world, the situation, or parts of the world, it was worse. Now, what would be the argument? I made the argument that once we have an effective deliverable, whether that be a vaccine or other preventive or a diagnostic or a therapeutic regimen, there needs to be a plan to deliver that innovation to those in greatest need. Well, this was very contested in the late 90s, as some of you will remember. There was widespread skepticism among those directing our largest development assistance programs, for example, many of them health programs, skepticism about using these drugs. And I've just pulled a couple of quotations from the arguments of those days, and I hope you'll remember the year is 1998, which is when we launched in Haiti the HIV Equity Initiative, and the year 2000, when comments were made about how this could not be done because of lack of infrastructure, lack of healthcare professionals, and lack of electricity. All those things were true. We lacked these things, but getting around them was not an insuperable problem. First of all, the price debate. In the years that some of these comments were made, you can see broad variation in the cost of a 3-drug suppressive regimen. I've listed a couple here. And the average wholesale price in the United States, which was over $10,000 per patient per year, and still is, by the way. The price that Partners in Health, the not-for-profit group that I was lucky enough to work with and still do, which was under $700 per patient per year at the same time, and then a promising even lower price of $300 per patient per year through the largest not-for-profit procurer of drugs, which is the International Dispensary Association based in the Netherlands. So even there, just looking at these numbers, you can imagine that claims about the cost effectiveness or lack thereof of this treatment were not very solid, in part because not only was this a moving target, the epidemic was a moving target, so too were the therapeutics, which were becoming more effective, but also the price was shifting over time, but also from place to place at the same time. And here's the other reason, other part of the argument. If there was not some aggressive and ambitious plan to deliver these therapies in the places most afflicted and to the people most in need, then this divergence, this outcome gap that you see here would broaden. The blue line represents what the World Health Organization called the Western world. That just meant the United States, Europe, parts of Asia, and AIDS deaths in Africa. So this split is one of the chief dramas of modern medical practice, and we see it in our clinical work when patients don't have ready access to some new intervention because of an insurance problem, or more commonly because when they leave our care and go home, we don't have a good way of making sure that they receive proper care. And this is especially true for chronic diseases, as I'll argue. ART, of course, just means antiretroviral therapy. Now, did this come to pass? Did this continue to worsen? And the answer there is no. In fact, that split did not continue to widen, and that was because of funding to help pay for the staff and the stuff and the systems that were needed to reach many millions of people. And this is just a graph of resources available for AIDS, largely focused on prevention and research until the Global Fund and PEPFAR, the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and the United States program, which is called PEPFAR, the President's Emergency Plan for AIDS Relief, came into being shortly after those claims of that we couldn't do this were made. And that moved very substantial resources into integrating AIDS prevention efforts and care for people with HIV disease. I just show this picture of one of our patients from Haiti who's asked that we use his real name and his picture. His name's Joseph. And Joseph was dying at home of AIDS and tuberculosis, and came into a clinic that we had set up using Global Fund resources, by the way, resources from this new multilateral fund to take on AIDS, tuberculosis, and malaria. And that's the same fellow a few months later after effective therapy, first for his active tuberculosis and then for HIV disease. And we see these very dramatic Lazarus-type, well, certainly the images, but we meet these patients all the time because you can take the successes of an individual patient and roll this out, as the term goes, to very large numbers of people with the help, as I'll show, of a very sophisticated system of care that looks like this. It involves substantial support for patients who have problems other than AIDS or tuberculosis. In this case, most of the AIDS patients in Haiti had tuberculosis. This is in the late 90s, before the advent of the funding streams, as I mentioned. And what we use to treat patients with AIDS was, of course, antiretroviral therapy, but also the system that had been built and laid out to treat tuberculosis, another chronic infectious disease. And that system relied on care being free of charge to patients, right? They didn't pay fees for their diagnosis or medications. And all around the world, that's what makes tuberculosis programs work. It also was complemented by substantial social support, and that included food support, help with transportation to the clinic, and every patient had a community health worker. And in Haiti, they were called acompañateurs, people who walk with you. And there were very striking improvements, which we've laid out elsewhere in the literature. I would just add that, as you might imagine, this was good for patients and their families. It was also very good for staff morale, that is, the doctors and the nurses working in these clinics. And this is true across Africa. In my experience, people were dispirited because so many of the patients that they saw had AIDS or AIDS and tuberculosis, and they didn't have the tools of the trade. That is, they didn't have the stuff and the systems they needed to use them. And this also led to a significant spike in interest in HIV testing, and I'll return to that in a second. Now, this is the sophisticated system, what it looks like. This is the same patient, by the way, Joseph, with his community health worker at home. She's come by to visit him, make sure he's taking his medications. And, it is a resource-intensive investment, but that is actually, in most of these places, one thing that people have is human capital. So they certainly, in Haiti, as in Rwanda, Malawi, Lesotho, et cetera, there are not the resources that we would have in the United States. And I'm heading actually to Sierra Leone tonight, where much the same conditions apply. That is, very little in the way of cash and for the medical services, but there is human capital. And that is one of the greatest expenses of the healthcare system in the United States, healthcare systems in the United States, elsewhere in North America, Europe, is the cost of salaries. But community health workers and who sometimes go on to other careers in nursing and medicine, there are people anxious to be trained and be part of this system. At least that's been our experience everywhere we've gone. And here's the way the healthcare delivery model works. It's not as if all problems can be dealt with by community health workers. That's not the argument. We're talking about the role of community health workers in community-based care for chronic disease. Much healthcare can and should be delivered in a clinic. And when you need something that, if you have a cough and even need a chest film, in many places in the world that would be done in a clinic. So too would vaccines be given or minor injuries be addressed, et cetera. In many of the places we work in the world, these are nurse-run clinics. And then finally, people do have catastrophic illness. Joseph, who doesn't need a hospital now, all these years later, did need hospital care. He was obtunded when he presented, and people do have obstructed labor. They do get hit by cars, et cetera. Hospitals are part of this system. But as they say a lot in the United States, it's not rocket science. It requires investment at all three levels of care. I would add that in the United States, our greatest weakness is community-based care rather than no hospitals. In some of the places I've worked, there are community health workers, but little in the way of hospitals, at least in the rural areas where we work, and health centers are understaffed and undersupplied. In any case, anywhere that I've worked and Partners in Health has worked, we've seen a need to strengthen all three of these levels. And in the United States, we really need to work on community-based care. Now, one little comment on this, and I will be glad to supply the references, but what about the impact of this integrating AIDS prevention and care on care for other illnesses, on efforts like improving vaccine administration? And what about in settings such as the shuttered or weak public hospitals across Haiti? Well, that was exactly how we laid out our initial plans in 2001, 2002, when we thought the Global Fund to Fight AIDS, Tuberculosis, and Malaria would be interested in supporting work like this. So we designed this program to improve primary care in general, and it did. First of all, people don't show up to clinic if there's no services, if there are no healthcare professionals, no supplies, and the place isn't well kept. But they do if there's something on offer. And if there's no patients, it's going to be very hard to do HIV testing, which is a cornerstone of HIV prevention and also management, of course, clinically. And you're not going to find patients with tuberculosis, and you're not going to improve the quality of prenatal care if there is not an easy link between, let's say, an AIDS clinic and a primary care clinic. So all of these things, and these are data from someplace in central Haiti, one of the first sites where we scaled up some of the HIV equity initiative's chief components. These are some of the data that showed in the first year or so of operation, there was a massive improvement in primary care in terms of not so much basic outcomes, but actually getting our hands on the patients who were not coming to these facilities. The question we heard an awful lot at that time, which was a little over a decade ago, was yes, but can it be brought to scale? Can you bring this to scale? I actually don't hear that question asked much in the Brigham and Women's Hospital here in Boston, but I hear it all the time when I'm working in settings of poverty. Yes, but can you bring it to scale? And this is the scale that we sought and achieved in the efforts in Haiti. And as you can see, everywhere there is a red dot, there is a ZL means Partners in Health in Creole. It's the sister organization of Partners in Health. It's an area where we have gone in and reopened a public hospital. Again, many of them had been shuttered. Very few of them were functioning effectively. And from the Dominican border, the border of the Dominican Republic, to the coast at the other side of the country, this same model of care has been brought to scale across all of central Haiti. And that's one of the reasons that we were contacted by the Rwandan health authorities in order to do something very similar in Rwanda. And so in 2004 and 2005, with the support of the Clinton Foundation, Partners in Health went to Rwanda along with our academic partners from Harvard Medical School and the Brigham and Women's Hospital to launch a very similar effort. And we had a very similar experience, and that is we found the public facilities back then to be in poor shape. This is one public hospital that had been virtually abandoned since the genocide and war. And so part of what we needed to do was rebuild that, but not before we could deliver this care, while we were delivering the care. So we rebuilt parts of this campus, all of it, in fact, and initiated care with some very critically ill, for some very critically ill people, some of whom later became our coworkers. This is, for example, a man, again, he asked me to use his name, John, who presented with HIV infection, but a fairly high CD4 count and a consumptive disease, as you can see. His chest X-ray was negative, but there are not that many consumptive diseases that can waste someone with a high CD4 count, and the chief one was tuberculosis. So he began empiric therapy for extrapulmonary tuberculosis, and this is the same man after treatment for both his afflictions, HIV disease, early HIV disease, and disseminated extrapulmonary TB. And as I've said to my students here at Harvard Medical School many times, he goes from looking like Skeletor to looking like he needs Lipitor, which is a good thing. How well does this work at scale? If you look at the first 1,000 or so patients and compare these results achieved in rural Rwanda to even a clinical trial in the United States, you see that the performance, again, with the help of community health workers, is superior to what you see in the United States. In fact, far superior. Looking at treatment cascades, we see that among Many cohorts in the United States, fewer than a third of patients are still in care 2 years after they initiate therapy. They're lost to follow-up because there aren't community health workers or nimble enough patients to follow them. Mortality, accordingly, is low, and so this is what the outcome should be if the therapy is correct. Among children, including adolescents, retention in care is even higher, and I think an American pediatrician, certainly an expert in adolescent medicine, would look at this cohort and think, wish we could do this. And again, it doesn't have to be HIV disease. It can be another chronic illness. But community health workers were key to these superb outcomes. Finally, what about the national scale? And here's where I think the Rwandan experience was better even than Haiti or anywhere else we've worked, because of a real commitment to making this approach national policy and to linking patients to care, including children and adolescents and women, but especially rural people who've been shut out of medical progress. Because of the commitment, the rate of enrollment was fairly rapid after this was outlined as the national plan, and the rate of decline in AIDS-related death was very rapid, as you can see. In fact, these are probably the fastest rates of decline in AIDS mortality ever documented anywhere in the world. And this is a national plan led by the health authorities, the Ministry of Health, and we were proud to be part of it and proud to still be part of it. Was it expensive? Was it because Rwanda had more resources? Well, the answer is it wasn't expensive, at least not in terms of the return, and Rwanda was, in fact, first over the line in terms of the target for universal access. That target changes, of course, on the continent, but also is a far poorer country than Botswana, for example, which also achieved the target, is slightly behind Botswana. And I've put the images for Haiti here because I think it's noteworthy that in spite of the earthquake in 2010 and the cholera epidemic that followed, Haiti has continued to improve in terms of its coverage with antiretroviral therapy and should be proud of that. Now, what about this claim that a so-called vertical program, that is a program that focuses on a specific disease, can be used to strengthen healthcare delivery in general? Rwanda was far and away the most intentional Ministry of Health, that is the public authorities in Rwanda were the most intentional about using these resources. Many of them came, as I said, from the United States and from the Global Fund to fight AIDS, tuberculosis, malaria, to use these and complement those resources with their own substantial resources and human capital to strengthen the entire health system during the course of these years. And as you can see, as expected, AIDS-related deaths dropped very dramatically, but so did all-cause death among children under 5. And, this is a stunning but not accidental achievement. Finally, I'd like to close by thinking a little bit about how the effects of these interventions, this community-based platform, can endure over time. These are patients from Haiti. Both of them required hospital care at the beginning of their illness because they were critically ill, and both began their antiretroviral therapy well over a decade ago. And here they are 10 years after starting their therapy, giving a lecture at Harvard University. And I would add that one of the reasons that we go through so many different regimens is because drug resistance ensues when patients are not able to take their therapies every day without interruption. And again, any of you who are listening to this presentation who might have a chronic disease will know it's difficult to take daily therapies, whether that's for hypertension or asthma. Humans are bad at it. And one of the things that we can do is make sure that everyone gets the accompaniment they need. Community health workers play a major role in preventing resistance, which means, of course, that the first-line drugs last longer for individual patients and on the level of a population. I'll just close with a very brief reflection on Ebola. As I mentioned, I'm headed back to Sierra Leone this afternoon. There's a major outbreak of Ebola, as everybody in the world seems to know, in West Africa, particularly afflicting Sierra Leone, Liberia, and Guinea. And it's worth stopping and reflecting on the other zoonosis from equatorial Africa that was unknown back in the late 60s and 70s when the hemorrhagic fevers were first described, and of course that's HIV. And I think the successes that we've seen in responding to AIDS, in integrating AIDS prevention and care, in providing community-based care for HIV disease needs to be replicated urgently vis-a-vis other infectious diseases, including tuberculosis. But also we can learn a lot of lessons that would be relevant to responding to Ebola, including lessons about how to link an emergency response to the longer-term health system strengthening work that needs to occur. And I'll close with this image of 3 Ebola survivors who we met not too long ago, just over a month ago in Sierra Leone. You see how young they are, 18, 25, and 15 years old. Each of them had been involved in caring for a family member sick with Ebola, because Ebola is in large part a caregiver's disease, and that's why physicians and nurses have been so heavily touched. But most care is given in the context of families. And although we read a lot in the popular press about zoonoses that come from eating bushmeat, this epidemic is being spread because of poor quality health systems. That's the primary cause of the epidemic. Its origins still remain somewhat mysterious, but the spread is person to person, and it's because of a lack of the stuff, the staff, the space you need to treat people, and the systems that could make this safer. And in order to turn this around, which I'm confident we'll do, we're going to have to require, as happened, again, less than 15 years ago with AIDS, we have to invest as a global community, since, again, these are global pandemics and will always remain so. I don't believe that they will spread far beyond places that have such weak health systems. There will be exported cases for sure. There have been already. But the real problem here is weak health systems. They need to be improved in order for us to stop this epidemic. So in conclusion, and I hope this is interesting to, and I believe relevant to clinicians who work largely in the United States, in each of these examples I've given, including the example of Ebola, emerging diseases emerge somewhere. They always do, but they spread through various means, and they reach people everywhere. So having this global approach is an important thing to do. 70% probably of tuberculosis cases in the United States, at least on the eastern or western seaboard, are diagnosed among the so-called foreign-born. That's just the nature of epidemic disease. And AIDS and Ebola, unknown in the 60s, emerged in the late 70s to become pandemics, one of them still regional, the other global. So it's important that American clinicians know about these problems. A second point in concluding is we know that social forces, including poverty and gender inequality, contribute to poor outcomes, both to the distribution of disease, that is a heavy burden of disease among the poor, but also to poor outcomes. The question is, can we address these social forces in the course of our clinical work and in providing services? And the answer is certainly. You need to complement medical knowledge with social services, and sometimes that involves transportation, housing, child care, et cetera, nutritional assistance. But it is eminently feasible. And our main partners, once patients are no longer critically ill, it should be community health workers. In the United States especially, there is not a national system for training, for recruiting, training, paying, and retaining community health workers. There should be, especially when we contemplate chronic disease in general. And here I've spoken about chronic infections like HIV and tuberculosis, and hepatitis C offers the same example, but so do malignancies. Even if they're not chronic in terms of the acute clinical course, caring for someone who survives cancer is a long-term proposition. And certainly when you consider diabetes, hypertension, asthma, major mental illness, you can imagine the utility of a care delivery system that stretches from our hospitals and clinics into people's homes with the help of community health workers. So I thank you for your attention and would be happy to provide additional materials for anyone who's listening to this and reaches me at my address at